but he's a master of every field in Ayurveda. He has trained thousands and thousands of students, and it's a really blessing to get him here on our platform to share his huge experiences, possibly in every field of Ayurveda. And today it's a small glimpse that we are going to have Sir's graceful opinions on this particular condition on cardiac disorders through Ayurveda. Most welcome, sir.
Okay, thank you. Now let me start with the Ayurvedic perspective of cardiac diseases, the clinical experience. That's the topic which I am supposed to deal with. Now, in general, whenever there is a issue of cardiac diseases, there is an awe in the society, both in the society as well as among the medical practitioners. People would always say that heart disease, there is something fear, awe as such. And many times it's felt like that cardiac diseases are in the scope of Ayurvedic practitioner. This is what general feeling. Many times that kind of a feeling does exist. Now, the question is whether Ayurvedic practitioners can deal with the cardiac diseases successfully or not. From my point of view, with my clinical experience, with the limited areas and with the specific discretion, we can successfully treat Ayurvedic these cardiac diseases with Ayurvedic means, and I am trying to share my experience with that. Now, starting with a bit of academics issue, the causes for Hridroga, the diseases of the heart, are as mentioned in the text. It's about the diet. Atishna, Guruvarna, Kashaya Chitta, Shramabhigata, Adhyashana Prasangehi, Sanjitvanehi, Vega Vidharneshta, Sadame, Panchavidha Pradishtaha. The causes for the heart diseases are mentioned as it could be dietary factor, or it could be the even exercise, either excess of exercise, or it could be the consumption of more heavy food, or even stress of any sorts. Or again, Sushila has mentioned the other same issue, Vegaghata, Ushna Rukshannehi, Atimatropasevitehi, Viruddha Adhyashana, Ajitnehi, Asatneshchapi Bhojanehi, Dushaitvarasam Doshaha, Viguna Hridayam Gutaha, Kurvant Hridaya Bhadam, Hridrogam Sampratyakshare. Sushila has again added in another specific context, Shantasya Nishwasa Vinigrahena, Hridrogam Moham, Athavapi Gulmaha. Now, in the present day situation, we have a lot of information about the risk factors related to the cardiac disease, particularly coronary disease, cardiovascular disease as a whole, and particularly coronary arterial disease. The risk factors are studied, and lots of information are over the risk factors. Now, in general, the risk factors which are mentioned, considered to be high risk factors by the authorities, are either high blood pressure, dietary risks, the 12 risk factors. The sequence or the ranking of them has slightly changed in the past 20 years as such. So, majority of these risk factors are well recorded, well documented as such, and most of these risk factors are the same which are mentioned in the text. As far as the cardiovascular issues and the death due to the cardiac ischemic heart disease, the risks are again, the sequence of them would be slightly more or slightly altered. Dietary risks come under the number 1, and high blood pressure comes under the 2, and air pollution and others in the, and high body mass index. Now, majority of these factors are can be preventable, can avoid, and in the heart disease, it's the most important is the prevention. Now, among those preventable and lifestyle factors which are well known to be cause for the risk cardiac diseases are the physical activity, and it's well known that sedentary lifestyle, the responsibility or the share of a sedentary lifestyle inducing the cardiac pathologies, particularly coronary disease. Now, when I say cardiac disease, here at this context, we will limit rather focusing on the ischemic heart disease, the coronary disease conditions. There the lack of exercise is considered to be one of the most important factors, and that's what Sushila has mentioned as a Shantasya Nishwasa Vinigrahena Hridroga. The cause of Hridroga being Shantasya Nishwasa Vinigraha, lack of physical activity. And interestingly, the incidence of lack of physical activity among the youth is widespread, and it's one of the major concern now, and it's a lack of physical activity, particularly in India. Now, I am very specific about Indian situation, and as per the global data study, the age between 11 to 17 years, the total physical activity is lesser, and it can be a cause for the majority, large number of diseases. And the next generation, we are going to have a generation of multiple diseases simply because of the lack of physical activity. Causes whatever may be the causes as such. And it's said that in India 72% of the boys were insufficiently active in 2016. This is the data presented in 2016 by WHO. And compared, and for girls, the lowest level of insufficient activity were seen in Bangladesh and India. The India and Bangladesh are considered to be the areas of concern, and it's a matter which everyone, not only the physicians or the others, everyone should be aware of this situation, and there is a need to do something about this issue as such. That's one. Another important cause for the cardiac disease is the junk food, the food as such, Vidahi Ahara. Relations between the junk food and the coronary diseases, they are now well established. Lot of documents are presented there, and lots of research articles are presented over there, and the incidence of the cardiovascular diseases with the food habits. You find the information from various sources. I have put in many of those scholarly articles references, and the summary what mentions is that those who eat these junk food 4 times or more per week, they have a high 80% chance of developing a cardiac heart disease, cardiac pathology. Whereas those who eat once in a week, they have 20% chance of developing the cardiac disease. So junk food of any sorts, that's what Sushil has mentioned as a Atyasna Guruvarna Kashaya Tikta food as such. That's exactly the same. The only the language is different, meaning is the same. Now, of course, you have some more structured data, more organized data. Sushil has mentioned as simply the causes. There is virtually no difference. And unfortunately, the culture of fast food and the junk food, it's increasing rapidly, and this is the commercial data of what's going to happen in the future. The future trend of India's eating out market is increasing so much, and it's one of the area where multinationals are entering in, and the people would have it's one of that factor which is going to generate a generation of diseased persons. So future generation, it's one of the facts which can be prevented. So from Ayurvedic literature point of view, we can now start educating the people. At least Ayurvedic doctors should avoid this as such. Then another most important cause for the a linked object, this fact related to the cardiac disease is the altered lipid metabolism. And the persons who have altered lipid metabolism, the incidence of the cardiac disease is increasing, and it's always the significant the relationship with the lipid metabolism altered. Again, about the lipid metabolism alteration and the facts, there is a lot of change in the perception. Earlier it was cholesterol which was supposed to be there, now it is LDL, and now we are going towards genetic factors. I will try to deal with that issue to a certain extent in detail later. Anyway, that's another of the causes which has to be known. And the obesity is another of the factor. The body mass index and coronary artery disease, the incidence is very obvious, and very important is it's not only that obesity, even a low body weight also increases the cardiac risk. So a ideal body mass index has to be maintained. If the body mass index is less than the optimum, there too the risk of cardiac complications are more, and those who are obese also, they have a higher risk of the cardiac disease. So maintenance of a ideal body mass index is one of the measures by which you can prevent. Another area of new information which is coming up, lots of information coming up, is a relationship between the status of the gut and the heart. Now, gut is becoming a main focus of many diseases. Gut-brain axis, which has already been now in the center of the modern medicine system. Gut and heart, gut and kidney, the relationship between these vital organs and the gut now has become a major area of interest, and lots of new research articles are coming up over there. Coming from Ayurvedic point of view, Basti, Pakpashaya being the center of Vata, and the Vata is the regulating authority, that fact is now being objectively ascertained. That's why Ayurvedic people now have to be very alert now. That concept of the Pakpashaya being the source for all that physical activity of the body now is being established, is evolving knowledge. And if you see the area of new articles, the number of articles coming up related to the gut and the heart and gut and the kidney, of course gut and brain, it has become almost old. Now this is another of the area where the relationship between the status of the gut or gut microbe as such, or microbiota, that environment of the gut situation, and relationship with the heart disease is another of the area which is coming up, and it will be a area of the future. So this now all that what I would like to say is the risk factors about the cardiac diseases mentioned in Ayurveda and what we now study, they are almost on similar lines. The only difference is now we have more objectively defined and data based information, whereas in Ayurvedic texts they are mentioned in a sequential form, simple language. And the incidence of cardiac diseases is increasing, and there is a very significant increase in India. The death due to cardiac diseases, the total incidence of the cardiac diseases increasing rapidly in India. From the national this data center, the data up to 2019 shows a very significant rise as such. Among the causes of the death in India, there is the incidence of cardiovascular death. Among all the causes of death due to cardiovascular diseases is the highest in India compared to other causes of the death as such. And another major area of concern in India compared to other global situation, the data in our situation is the incidence of cardiovascular coronary artery disease, very specifically coronary artery disease, in persons of less than 30 years of age also is increasing, which is an unusual phenomenon compared to other countries. Now, the issue is in the Western countries, more developed nations, the deaths due to cardiovascular diseases is on a declining trend. It's reducing, whereas in India it's increasing. And it's not simply that increasing. Another major area of concern is it's affecting more younger people, which is not a common situation. This data where the age group of 30s being affected with the, or less than 30s being affected with the cardiac disease, and increasing trend 2010 to 2015 there is a significant increase. This kind of a percentage increase in the younger generation is another of the major area of concern, and that's where from Ayurvedic point of view we have to play more proactive role to convey the message of the proper use of that preventing measures. Swasthavata concepts, they have to be now rather maybe more forcefully presented for the sake of the society. This is where Ayurvedic principles are required in the area of cardiology for the prevention, and that principle is hitahara upayogaha ekayeva purusha vruddhikaro bhavati ahita ahara upayogaha punarvyadi nimittamiti naro hitahara vihara sevi samikshakari vishesha sattvaha दाता समः सत्यपर क्षमावान आत्मोपसेवी च भवत्यरोगः मतिः वचः कर्म सुखानुबन्धं सत्वं विधेयं सदा च बुद्धिः ज्ञानं तपस्तत्परता च योगे शास्त्रि तं न अनुपसन्ति रोगाः. So this kind of prevention of the disease with that correct message, proper message, and a need for the lifestyle modification, this has to be a area where we need to educate the society, and we need to convey this message and save the future generation from the possible risks. That's one point. And whatever is mentioned in the present day situation, 5 ways to prevent the cardiac disease, heart disease and stroke, what is mentioned now, almost are on the same line. Of course, you have certain specific issues like exercise, nutrition. There is some description, but what I would say is the Swasthavata, the concept of Swasthavata concept of the whole the sadachara, that ruchacharya, and as such, they are more practicable and they need to be now brought into the practice for the society, or at least for the Ayurvedic doctors, faculty of Ayurvedic people, fraternity of Ayurvedic people. They need to follow, develop some faith in it. That's one of the important message. Of course, now among the five, the mentioned are the prevention of the tobacco, and that social factors. Of course, aspirin is considered to be another preventive factors as such. That's one. Now, when it comes to the question of dealing with the cardiovascular disease, from the general clinical point of view, the most important condition which is considered to be having a close association with the cardiac disease and it needs to be treated is hypertension. Now, history of hypertension, that knowledge about the hypertension and its clinical use is quite recent, quite new one. Acharya Sushruta or Chanaka have not mentioned about hypertension. They could not mention the hypertension because the blood pressure could not be measured without cutting the tissue till 1896. In 1896, for the first time, a possibility of measuring the blood pressure by using a cuff-based sphygmomanometer was invented by Italian physician called Scipione Righi. But later on, it was standardized. Early, it was brought into the clinical use by Korsakov, that Nikolai Korsakov, a Russian physician. And even now, whenever we record the blood pressure, the sounds heard are named as Korsakov sounds for the remembering that physician. So the whole history of hypertension in the medicine, modern medicine, is just around 200 plus years. 1905, now 2100. So something around 200 plus years history. Earlier to that, the idea of hypertension and the treatment of the hypertension was not existing at all. Between 1910 and 1914, physicians made headway in defining the essential hypertension, normal and abnormal, and malignant hypertension, complications due to the hypertension. They were just studied because you have a large, huge number of people who have hypertension but they do not have the symptoms as such. Real clinical uses and the real advantage of treating the hypertension came in only after the President Roosevelt's death, because Roosevelt had that hypertension and then he died. That's in 1948. So the real practical clinical utility of hypertension and evolving concepts of dealing with hypertension and standardizing the treatment of the hypertension has come up only from 1948 onwards. Till then, of course, there was some perception of the hypertension being responsible for the diseases and cardiac origin also on, but real concept developed from 1948. So, hypertension is a very young disease and maybe as young as our nation, India, 1948. So, that could be the other way we can mention. And you do not expect Ayurvedic literature to mention about the hypertension in detail. But I will try to see similar issues, like whatever the symptoms are mentioned. Based upon that, whatever Sushruta or Charaka have mentioned, we can try to deal with, and we need to modulate certain methods of dealing with the hypertension. I will try to share with my experience of dealing with the hypertension patients as we see. Now, of course, from the history point of view, that Framingham risk score is a benchmark in the hypertension management. Based upon the data, again, there is a lot of controversy, like what would be the normal hypertension, and there are a lot of controversy about the changing that benchmark of hypertension also. But I am trying to come to the latest point without going into that controversial issues of promoting the market and so on, but universally accepted. Now, American Heart Association advised standards of hypertension. The normal is considered to be less than 120 and diastolic pressure is less than 80. Elevated is 120 to 129 and diastolic pressure less than 80. And high blood pressure is 130 to 139 and it is diastolic pressure is 80 to 89. Whereas high blood pressure is 140 or higher and 90 or higher as the diastolic pressure. Now, the idea of that benchmark of the normal hypertension has been changed in years regularly. When we were studying, like in 82, when I was studying in PG, we used to say that a diastolic pressure of 90 and systolic pressure of more than 160 was considered to be a hypertension that needs to be treated. The pressure below that need not be treated. That's what it. But gradually, every year or maybe at regular intervals, these benchmarks are reduced, lower, and of course there is another school of thought or another popular school which is presenting as a systolic pressure of less than 60 also being diastolic pressure of less than 60 being considered as a normal also is coming up. Of course, there is another view. I am not going to that part of controversy. The other view is this kind of changing that benchmark of the blood pressure, normal blood pressure, is related to the commercial interests of the company. As the drugs are coming up, newer drugs are coming up in antihypertensive drug market. These are changed. This is one version. Again, I am not going to that part. Of course, we have. It is a part where we can debate for hours together with sufficient data. The interests of those commercial markets, but I will not go into that part, but I will just refer to the normal pressure range. Practically what happens is, when you look at the patients in our situation, in Indian situation, this is about the Western normal. In our situation, if you look at the people, we rarely find the patients who have a pressure of less than 120 to less than 80 or 120 by 80, less than that. In a middle-aged persons, we rarely come across this, and in our situation, majority of the people would have 140 to 90 as the average blood pressure. And from my practical point of view, among my patients, I consider 140 and 90 as the level where you need to intervene or where you need to treat. Below that, there is no need of treatment as such. This is now the data also are presented in that manner. Maybe that part of the controversy, like whether how far it is true and so on, and the data about that may not be or within the scope of what we can discuss today, but I have sufficient data about that. Anyway, that's one part. Now, when a patient comes to Ayurvedic treatment point of view, and I'm just dealing with the scope of or spectrum of hypertension patients in my practice. What I have seen on an average, now when I have mentioned this percentage is somewhat average, may not be very accurate. Now, this kind of a classification is needed to plan the strategy of treatment. Now, because all these issues, all these controversy is, as we do not have a obvious standard literature about the hypertension in Ayurvedic text. So when we deal with the patients, we need to be very careful, and that risk prediction and risk avoiding is one of the important criteria. Safety of the patient is another important criteria which we have to consider. So from that point of view, I deal with the patients of hypertension with this following the strategic approach, a step-by-step approach. Now, among the patients whom I see, the majority of the patients come with a stabilized blood pressure and having a history of either cerebrovascular accident or a coronary issue, arterial diseases, CVA or CVD. Patients with the stabilized blood pressure, they come under the larger group of my patients. This spectrum of the patients may vary from physician to physician, and another next is either newly diagnosed to primary asymptomatic hypertension patients. One category of patients are, they do not have any symptoms, but they have come for some other purpose, and when I record the blood pressure as a routine, the blood pressure may be on the higher range, and when I say higher range, in my practice I consider 140 by 90 as the range where you need to intervene. I am not following exactly the same line, because if you follow that 120 by 80, more than 80% of the patients whom we see in the middle age, they could be considered as the hypertensive patients. And naturally, if a patient, such a person goes to any contemporary medicine person, he will be on antihypertensive. So antihypertensive drugs are being prescribed, and then you will have a real problem like whether those antihypertensive drugs can be stopped or so on. So this is one of the sensitive area which I will try to deal with from my point of view. Then another patients are newly diagnosed patients with some symptoms of hypertension. Symptoms of hypertension could be either giddiness or headache, these abnormalities of the mood, or maybe involvement of the other organs. I'll try to deal with in detail about this group also. Then patients who are on antihypertensive drugs as such and have a stable pressure status, and some of them may have an interest to change over to Ayurvedic management. They constitute another group of the people. They are already on antihypertensive drugs and the blood pressure has become stable, but they now want to have some craze, somehow they have some interest in Ayurvedic treatment, and they come to us saying like, ನೀವು ಆಯುರ್ವೇದದಲ್ಲಿ ಏನು ಮಾಡ್ತೀರಿ ಬಿಪಿಗೆ, ನೀವು whether you can give treat or not, this kind of questions, and that constitutes another group of the patients. Another group of the patients are who are antihypertensive, on antihypertensive but not stabilized, and they are opting for Ayurvedic treatment either as a main prescription or maybe as a co-prescription. On antihypertensive drugs and having obvious adverse effects of the drugs, another category. Patients who have on modern drugs and have some adverse effects of the drugs, and this is another category, and we will have to strategize for these patients also. Patients coming with acute complications like coronary vascular or cerebrovascular accident or coronary ischemia or any sort of malignant hypertension, that constitutes one more. And secondary hypertension conditions. Now, when I say secondary hypertension conditions, patients who have disease of other systems like renal or other pathologies, toxic pathologies, and having hypertension, they constitute another group. And this is the spectrum, average spectrum of the patients whom I have seen in my practice. Now, this spectrum may change from one practitioner to the other, but what I am saying is we need to plan the management of these patients based upon these primary issues, and we should do a justice to the society, to the suffering people, considering the available facilities and safety of the contemporary system, and ensure that the patient is not put to loss because he has come for an Ayurvedic treatment. These are the basic guidelines, and based upon that, I will be treating these patients. And in brief, without going into much detail, in brief, the strategies which I would like to plan would be, if the patient has a acute end organ involvement like a coronary accident or cerebrovascular accidents, in that condition, from my experience point of view, our standalone Ayurvedic treatment, I don't believe or I don't depend upon only our Ayurvedic treatment approach in such conditions, because the time is important factor, life is precious. A patient of CVA coming to me with immediately after the attack, I will be definitely using some contemporary antihypertensive drugs to stabilize the patient. Till the patient is stabilized, we need to do that. And from my point of view, standalone Ayurvedic treatment may not be enough to safeguard the interest of the patient. So I will usually prescribe Ayurvedic treatment along with that, but primarily the contemporary antihypertensive drug may be prescribed. I will be prescribing them without any hesitation, or I will be referring the patient to some other center if they are interested. Then the patients who are on antihypertensive drugs with the stabilized status, that there are no issues, and the patient just comes casually, whether I would be dealing with that patient from a Ayurvedic point of view or not is again depending upon the patient and my relationship. If the patient has come with a casual approach, like to see whether Ayurvedic treatment helps or not, without having a commitment, I will be trying to keep that patient away, preferably without modifying, to ensure that the same drug is maintained as such. Only in certain patients where we cannot do that due to our interpersonal relationship, I may take up that patient for the treatment. Then on antihypertensive drugs but not stabilized with the complications like CVA, in that situation, my basic approach is maintain the existing regime and plan the management. The existing drug has to be maintained, along with that our drugs, Ayurvedic drugs, are prescribed. So that's the rough strategy for such group of the patients where the patients come with established hypertension and hypertension related complications, or patients who are having a treatment. Now, what are the drugs and how it is done? I will try to deal with that at the end. I will summarize that at the end. Now, the other way, if a patient comes to me with a new hypertensive condition and I diagnose that as hypertension, whether the patient requires a treatment or not, whether the patient requires a management, that blood pressure has to be recorded or not, is again depending upon one, whether the patient has any symptoms or not. A patient who presents with the symptoms of hypertension like giddiness, palpitation, or exertional dyspnea and so on, there is no question the patient has to be treated. If the patient doesn't have those symptoms and the patient is your recorded blood pressure is higher, and of course I always follow that general protocol of recording the blood pressure, like at least 3 recordings have to be done, and if consistent 3 recordings show a higher pressure, then only I will consider that as hypertension and treat the patient. A single recording may not be enough to consider the patient as hypertensive, particularly in those who are asymptomatic. Of course, in asymptomatic and patients who have complications, that criteria doesn't exist. You will not wait for 3 recordings. But in the other patients, I will obviously wait for 3 recordings. And then the next would be the ECG is one of the criteria. If the ECG shows changes of hypertension, like widening of the P wave and widening of the T wave and raising of the T wave, then there is a tendency that there is a cardiac load, and it suggests about the possible requirement for the hypertension. If there is a very high increase in the QR wave suggestive of the cardiomegaly, no doubt about that, the patient has to be treated for the hypertension. So that's one of the criteria. Another of the criteria is the echocardiogram, and the usual my benchmark would be if RRS wave is greater than 20 mm in any lead, definitely yes, the patient requires treatment. If the R wave in lead 5 or 6 is more than 30 mm, that's a sign of ventricular hypertrophy, and that patient needs treatment, effective treatment for the hypertension. Blood pressure has to be reduced. QRS duration is more than 0.09 seconds, the widening of that QRS complex, then 2, the patient requires hypertension. ST depression or T inversion also is another sign of caution, where you need to be very energetic about the treatment of hypertension. And another benchmark criteria which earlier, with older cardiologists were depending, now the current cardiology guidelines have removed that part, is the thickness of the ventricular wall seen under echocardiography. If you do the echocardiography, and if the ventricular wall thickness is more than 12 mm, that's also considered as a sign of ventricular hypertrophy, and it was considered as one of the criteria for treating the patients of hypertension earlier, but now the current cardiologists don't accept that. They say that even if the other way, if the blood pressure is recorded high, they suggest the treatment. Now, my perception is, or whatever the criteria which I am following, is not the current guideline of the current cardiologist generation. Current cardiologists would have a different perception, and this criteria was a bit older, and based upon my clinical experience, I would say that this criteria still is valid. There is no need to change to the new guideline as such. Now, my perception of hypertension based upon Ayurvedic this treatment would be, or Ayurvedic perception would be, there are of course lots of people, Ayurvedic people would be giving some names to the hypertension and so on, but from my point of view, the hypertension being a silent killer which doesn't produce the symptoms earlier, but later on it results in significant complications. It's one of the variety of Avrutavata. In general, what Vagbhat has said, Avrutah Vayu Ajnataha Jnatava Samstiraha Prayatnena Vidussadhyaha Bhavayuhuva Anupakramaha. Initially asymptomatic conditions which result in a later significant complications or become incurable. This is a description of general features of the Avrutavata, and I would consider hypertension as some variety of Avrutavata. Which of the variety of Avrutavata would be depending upon the clinical symptoms and the other status of the patient. And it's considered like Avarana is responsible for, Charaka has mentioned same, the diseases like Hridroga, Vidradhi, Pliha, Gulmo, Atisara Evacha, Bhavanti Upatravaha Tesham, Avutranam Upekshanata. Avrutavayati, when it is neglected, not treated properly, it can result in Hridroga, very obviously about the hypertension, and of course the other varieties of Avrutavata can result in Vidradhi, Pliha and so on. So basically, I would be considered hypertension as a Avrutavata, and the primary approach to the treatment would be in terms of treating the Avartavata. In Avartavata, the Avaraka has to be treated first and Avarta has to be treated next, and you need to have a Achana Chikitsa than really the Snehana Chikitsa. So that's the basic approach, primary approach as such. The other way, the more of textual description, more theory of this hypertension would be, though Sushruta has not mentioned, our Ayurvedic acharyas have not mentioned the blood pressure as a criteria, and quite naturally they cannot mention, because the instruments to measure this blood pressure was not available at that time. But still, the description or possibility of physiology of circulating pressure were well known, and Sushruta has clearly mentioned about the circulation where the blood moves from heart to the siras, and in the sira again it comes back to the heart. This kind of a closed circulation is mentioned by Sushruta in the description of Sapta Sirashatani Bhavanti Yabhi Idam Shariram Araya Jalaharanibihi Aramaiva Jalaharanibihi Ketaraiva Kulyabihi Upasnishate Anukrishate Akumchana Prasaranadibihi Visheshehi Drupapatra Sevaninam Tasam Pratana. This is a perfect description of the circulation. Of course, we attribute the invention of the credit of inventing circulation to William Harvey in 1850s, whereas Sushruta has described that much earlier, so that's a copyright issue. Anyway, we will not go into that part beyond that, not creating controversy. Whereas in Ashtanga Sangraha, there is a very specific word, the Prana Vata. Among the functions of the Prana Vata, one of the function is Dhammani Dharana, the maintenance of the vessels, the shape of the vessels, hydrostatic pressure. Maintenance of the hydrostatic pressure is one of the function of the circulating chamber, and this is exactly mentioned by Vagbhata in Ashtanga Sangraha as a Dhammani Dharana. So that's about the possible textual description. And of course, Vagbhata has mentioned about the functions of that circulation as a whole, as Vanyana Rasadabhihi, Vikshepotita Karmana, Yuga Pasavato Ajastram Dehe, Vikshepire Sada, Kshipyamanaha, Kavai Gunyata. Then, of course, how the disease occurs. So, that phenomena of a circulation, diffusion of the substances across the body as the main function of the circulation is described in the text as such. Now, coming to the hypertension, now planning for the hypertension and the management, primarily the hypertensions are categorized into three categories: renal, metabolic and vascular. So blood pressure is primarily these, that's renal is the situation where the total circulatory volume has increased due to renal pathology, and this can result in accumulation of the fluid, and hence there would be hypertension. Metabolic pathology is where there is some abnormal metabolic substances created, and these metabolic substances can result in weight loss, and again that can also result in hypertension. Or vascular pathology. More important is the vascular pathology, where the blood vessels changes, the consistency would be altered. It may become narrowed, either it could be due to the spasm or due to the deposition. There could be spasmodic condition of these. And the total approach to the hypertension, selection of the drugs in the contemporary system, whatever now I am suggesting is a bit not exactly an Ayurvedic view, but it's sort of a borrowed view from the contemporary system to my practice. So whenever you select an anti-hypertensive drug from the contemporary approach point of view, the primarily one issue, of course there are multiple criteria to select the drugs. One of the criteria would be whether the patient is a hypervolemic patient, whether the patient is having a spasm of vascular peripheral resistance being increased, or whether the patient has some metabolic pathology. And based upon that, the drugs are selected. Now, in all such patients, one of the important would be the lifestyle and dietary counseling is necessary, which is common for all patients of that hypertension. Whereas, if the patient is of that category where there is a increased volume being responsible, as the contemporary medicines, it's the diuretics which are prescribed, I would be prescribing Punarna Mandura. I don't say that my selection of these drugs is not based upon Ayurvedic principles. It's because it's practicable and it's a seen asset, and results are seen. If the patient has that dosha dushti, that metabolic pathology, as a Rasayana, I would be preferring Chandra Prabhavati, and if the patient has a vascular spasm and so on, I will be prescribing Saraswatarista as Vata Shamaka Dravya. So the idea, there is a bit of, if you say that it is a rather polluted perception or not a correct Ayurvedic perspective, okay, I agree, but this gives the results. So in majority of the patients of hypertension, my prescription moves around Chandraprabha, Punarnamandura, Saraswatarista. Whenever in many of the patients you may have all the three categories of the pathology, in that condition my prescription may consider all these. And this is particularly in asymptomatic patients of hypertension, patients who do not have a symptom of hypertension, but I would consider that the patient needs a treatment for the hypertension based upon whatever I said earlier about that total diastolic pressure being 90, or the ECG changes, or maybe the echocardiography changes, and the patients who have not taken any treatment earlier, a fresh new case where there are no other treatment given, my prescription moves around Chandraprabha, Punarnamandura, Saraswatarista. And I can say good number of patients show very positive response, and within 2 to 3 weeks you can see a steady reduction in the blood pressure, and a patient may not develop any symptoms, and in a large number of patients even I have discontinued the medicines, but lifestyle and dietary counseling has to be maintained, and lifestyle is a basic is a rigorous exercise, at least 1 hour walk every day, and dietary reduction of spicy materials, Guru Ushna Ahara has to be avoided. With this, a large number of asymptomatic new cases of hypertension can be effectively managed, and the results are as good as any other contemporary system. Rather, to a certain extent, they are better, because none of these drugs would have any significant adverse effects, whereas the adverse effects of the contemporary drugs are quite significant, and that we need to treat them. Then comes the symptomatic patients of hypertension, patients who have the symptoms of hypertension. In that condition, one group of the patients I would consider them as a Udanavarta Prana, particularly those who have dyspnea. Nishwasa, Uchvasa Samrodha, Pratishaya, Shirograha, Hridrogaha, Mukashoshascha, Pranena, Udanavarte, Pranena or Pranena Avrata Udana or Udanena Avrata Prana. So Prana Avrata Udana or Udana Avrata Prana, both of them are, I would consider as a hypertensive patients with the symptoms of dyspnea on exertion or cardiomegaly, signs of cardiomegaly, involvement of maybe the ST changes as such. I would consider them as a Udanavarta Prana. Particularly dyspnea on exertion and cardiac enlargement as a presentation of hypertension. In that condition, I would consider them as a Udanavarta Prana or Pranavarta Udana. And in these conditions, the responses are not very consistent. I would not say that as good as in asymptomatic patient, the treatment would be very effective, but my prescription would be usually Chandraprabha, Punarnamandura and Avibhakti Churna is my usual prescription, and with this a good number of patients may show positive responses. If the patient doesn't show any response, my criteria is I will be managing the patients for about 2 to 3 weeks with these medicines alone, if the patient is not taking any medicines earlier. If the patient is not on antihypertensive drugs, I will be treating this for 2 to 3 weeks. If the patient shows sufficient satisfactory response as their blood pressure as well as the symptoms are reduced, we maintain that patient on the same. If the patient doesn't show the sufficient response, the patient is supplemented with the contemporary antihypertensive drugs based upon the principles of the pharmacology. If the patient is already on antihypertensive drugs and comes with these symptoms, naturally this would be the prescription, and in such patients the patient would always show a positive response. This is one approach with the treatment. Then the next of the patients, category of the patients who develop the symptoms would be Brahma, giddiness. Brahma Murcha Rugadaha Pittena Prana Avrate, Pitta Avrata Prana, or it also could be in case of the Pitta Avrata Udana. There Brahmadaya, the Brahma are the symptoms there. And patients who present with giddiness as a symptom of hypertension, my approach would be considering this as a Pittavarta Prana or Udana, Pittavarta Udana. My prescription would be Chandraprabha, Kamaduga, Bhunimbadikwata, and or many times Saraswatarista also. And the Virachana gives very dependable results in this category. I will follow the Virechana with the Pradhitikta Gulgurta Snehana, and the Virechana is given with the usual Trivutleha, and this gives very significant satisfactory results in the patients who are symptomatic with giddiness. Patients with the giddiness as a symptom, that's the Pitta Varta Prana, the results are much better than patients who have dyspnea as the clinical symptoms as such. I may not be in a position to give you a statistical data in numbers, right? But this is a gross perception, and it's absolutely true because I do not have that kind of a structured data maintained to give you statistical data. But this information is quite practical, and it's seen. Patients would have good results, and with the Virechana also, the patient's results are quite dependable. In many of the patients, if the patient is on contemporary antihypertensive drugs, I can reduce them or I can withdraw them. So whenever a patient is on contemporary antihypertensive drug, my approach is I don't reduce them immediately. As the patient shows the response gradually, one by one it can be reduced. Either dose can be reduced or dose medicine can be withdrawn. A large number of patients we could withdraw all the drugs with the Virechana following with the Chandraprabha Kamaduga like treatment in the patients who present with the giddiness as symptom. Then the patients who present with the transient ischemic attacks and neuritis, the another category of the patients of hypertension, there I would consider them as a Pitta Varta Vyana. There again, the clinical symptoms mentioned in Samhita are also same. Daha Vyane cha sarvagam daha klamaha Angacheshta Sangaha, Sasantapaha, Savedana. These are the clinical symptoms, and that's exactly what you see in the patients of transient ischemic attacks or neuritis conditions as a complication of the hypertension, or maybe one of the presentations of the hypertension. In such conditions, my treatment prescription would be Chandraprabha, Ekangvira, Manjistadi Vata, or Ashwagandharishta, depending upon whether the patient presents with the Daha or Santapa. If it's a presentation with the Daha Santapa, it's a Manjistadi. If it is a Chesta Sanga, like typical neuritis, it's Ashwagandharishta. That's how it is prescribed. Treatment with the Matra Basti or Rajayapana Basti also gives very satisfactory results. It can stabilize the patient's symptoms, can be effectively reduced, and the results of maintaining of the blood pressure also is possible, though not as high as that giddiness categories, Pitta Varta Vyana category, Pitta Varta Prana category. Pitta Varta Vyana category may not have the same percentage of patients where we can withdraw the drugs, but to a great extent we can reduce the drugs, other antihypertensive drugs, or we can manage without the antihypertensive drugs to a certain extent as in such categories of the patients. That's one of the prescription. Then another of the patients who present with obesity and hypertension, dyslipidemia, patients with the altered lipid profile conditions. In that condition, the basic approach is whether the patient has already having antihypertensive drugs or not. That's one of the criteria which is a general follow. But I would consider this as a Kapha Varta Udana, Vyana or Prana. In Kapha Varta conditions, the Guru Gatrapam, Aruchi, Vakswaragraha, Balavarna Pranashashta. In Kapha Varta Vyana, Parvasti Vagraha, Guruta Angeshu, Sarveshu, Skhalitam Jagata Ubrisham. That's exactly the features which you see in case of the obesity. So obesity and hypertension treatment, my prescription would be Chandraprabha and Kapha Varta, considering this as Kapha Varta Udana, my prescription would be Chandraprabha, Arogyavardhini and Avipattigara, Anulomana Aushadhi, and Agni Chikitsa, which is one of the treatment which we follow as a Pachana Chikitsa in our unit, SDM hospital since a long time. It's not really a textual treatment, it's a treatment which we follow there in SDM hospital. LEPA, application of the LEPA, which many of our students know about it. Then Chara Basti or Matra Basti. Basti is the usual prescription in such conditions. As far as the response is concerned, patient, the outcome would be good, but not as dependable as the other categories. Most of the times, it may not be possible to withdraw the antihypertensive drugs, but the dose can be reduced in certain conditions, and at least the symptoms and progression of the disease can be definitely arrested. complications of the hypertension can be definitely prevented when we prescribe these drugs along with the other antihypertensive drugs in the contemporary system. Then patients who coming with the hypertensive encephalopathy, any acute emergency, where I would consider them as a mother, the Raktaja mother, only the hypertensive encephalopathy condition I would consider as Raktaja mother. In such conditions, it presents with the altered consciousness, irritability, many times convulsions, and in such conditions, the primary approach would be, of course, the exact description of these conditions are Alpadruta Abhasham, Chalaskalita Chesitam, Vidya Madavisham. These are the typical of Vatajamada Lakshanas, or in case of Pitajamata also, Raktapita Asitakritim, Swarpa Asambadhavachanam, Tanda Alasasamanvitam. These also are the typical symptoms of hypertension. In these conditions, I don't suggest any specific, this is a very specific issue, because the patient presenting with the hypertensive encephalopathy is an acute emergency, and the most important would be you need to ensure that the patient is continuing to live. So life support, if there is a need for that life support, like maybe Rayleigh tube or maybe catheterization, or if necessary ventilation, depending upon the patient's presentation, that life support is necessary as per the necessity. I don't consider that we can manage such patients only with the Ayurvedic treatment and in a OPD basis. And the important is blood pressure has to be managed as early as possible. The time is an important factor. So reduction of the blood pressure with the contemporary drugs as per the necessity is prescribed. I will not go into the pharmacology of antihypertensive drugs now. And it's necessary whether I prescribe the drug or whether the patient is sent to other hospital. That depends upon the patient's relationship with our setup as such. And if the patient is continuing to our treatment after managing the hypertension, my usual prescription would be Chandraprabha Ekangavira Abhrakatapyadi Godanjava Pratigara Agnichikitsa and Matra Basti. With this, the patients may have significant clinical relief, much better than being treated only with the antihypertensive drugs. The outcome would be much better than the contemporary treatment. But I don't say that we can manage such patients only with our treatment alone. That's one of the important issues. But now that's about, in brief, about my strategy to dealing with the hypertensive patients. Now another important area where we can do a lot would be patients presenting with or patients being treated with the antihypertensive drugs and having the adverse effects of the antihypertensive drugs. And well-known adverse effects, and that adverse effects of the antihypertensive drugs are a well-known entity, and it's also established as a ICD diagnosis code of T46. So it's an established entity in the contemporary system, and where the contemporary system doesn't have any significant practically usable approach. Of course, there are a lot of issues about that, but from our clinical point of view, we can produce a huge changes in the patient in these categories. Particularly the patients of beta blockers, these adverse effects are cardiac issues like bradycardia, AV block, dizziness, fatigue, depression, diarrhea, etc., or bronchospasm. In these conditions, my prescription would be Chandraprabha and Saraswatista. When I prescribe Chandraprabha Saraswatista along with the antihypertensive drugs, beta blocker drugs, the adverse effects can be significantly reduced, and to a great extent we can reduce the dosage of the beta blockers through reduction of the dosage of the beta blockers can even reduce the effects as such. So among the commonly used drugs, beta blockers are very commonly used drugs in case of the antihypertensive management, and a large number of patients after a few years of treatment, they develop these complications, these adverse effects. Instead of using the word complications, it's adverse effects, and these adverse effects can be effectively managed with Chandraprabha Saraswatista, and that's one area where Ayurvedic treatment can do a lot. Now patients on alpha blockers, of course the incidence of alpha blockers being prescribed for the hypertension is lesser, but they tend to develop usually the symptoms like orthostatic hypotension, giddiness on standing erect, tachycardia, vertigo, syncope, etc. In these conditions, my prescription would be Prabhakaravati and Kumaryasava. So a possible Hridroga and Agnimandya. The treatment would be on that, and symptoms can be effectively reduced. And in the patients who have calcium channel blockers, another group of the antihypertensive drugs, I am not going to the individual drug detail, in group as such, the adverse effects often produce are bradycardia or tachycardia, ventricular fibrillation, such are the symptoms, or the patient may even develop peripheral edema, another very common complications of the beta blockers, constipation, and anorexia, gastrointestinal tract symptoms. My usual prescription would be Arogyavardhini and Manjustat, and calcium channel blockers are also another more commonly prescribed drugs. Then the ARBs, like in that condition, the patient may have angioedema and dry cough, hyperkalemia, etc. In these conditions, my prescription would be Chandraprabha and Sarasvarishta. And patients who are on diuretic therapy, they may develop the symptoms like orthostatic hypotension, diarrhea, and in these conditions, usually my prescription would be Ashwagandha. Comparatively, the adverse effect would be lesser with the diuretic drugs. Now, the other issue, next issue from the management, that's in brief about my approach to the treat patients of hypertension. Next of the issue related to the cardiovascular pathology and the prevention is about the hypercholesterolemia or altered lipid profile. Now, as the fact which I referred to earlier about the altered lipid profile and its target, the information coming up or information developed also is very rapidly changing. Every year there is some new information coming up, and that perception also has changed. Very significant changes would be in earlier days, like 1900 to 1950, cholesterol was considered to be the responsible for the cardiac complications of altered lipid profile. But later on, now the low density lipids were identified. Now, very recently, the genes which are responsible, proprotein convertase genes, stabilizing genes are identified, and familial cholesterolemia is considered to be one of the important factors. I will not go into much detail about these issues, but as you know, the practitioners know about them. Now, my prescription in hypercholesterolemia, my perception is that as far as the risk factors of hypercholesterolemia is concerned, the most important is the diet can reduce these complications significantly. Most of these conditions can be prevented, complications can be prevented with the diet. Cholesterol level also can be stabilized to a great extent with the diet and exercise. So, diet and exercise forms the key role in case of the management of the cholesterol than really the medicines or the drugs. As far as the drug is concerned, the medicines are concerned, my prescription, my experience in that clinical field would be, I would be prescribing Chandraprabha, Arogyavardhini, Kumaryasava as a Rasayana Aushadhi as well as a Agnidipana Aushadhi for the treatment of Medo dosha, and it produces a significant change in the lipid profile provided the patient follows the diet and exercise. If the patient doesn't follow the diet restrictions, none of the treatment, not even contemporary system medicine or our medicines, can produce the changes in the outcome. So, most important factor is the diet. If the patient maintains that diet restrictions and exercise restrictions, decisive and remarkable changes also can be produced by Virechana. So, I do prescribe Virechana in such patients, and Virechana gives a significant outcome. And at least during the course of Virechana and the Sansajana Krama, the lipid profile can be significantly changed. Whether the same level can be maintained or not, it depends upon whether the patient maintains the diet or not. Now, whether the cholesterol level or changing this lipid profile can reduce the coronary arterial disease risk or whether it can prevent that or not, it's an area of controversy. Even in the contemporary system, people have some difference of opinion. So, that part I will not go into that. But whether reduction of this cholesterol level or the lipid levels, low density lipid levels can prevent the coronary artery disease or not. It's a gray area. Of course, there are many contemporary physicians swear that it can be reduced. but there are data which is representing the other way also. Anyway, I will not go into that part of the controversy, but as per the general norms, reduction of the cholesterol level or lipid levels, low density lipid levels, is considered to be one of the safety steps, and from Ayurvedic point of view, we can contribute to a certain extent in that area also. That's the one of the issues. The next is about the other substances which can be advised to reduce the cholesterol level. The commonly used substances in the diet and may not be in the scope of medicines are Lashuna and Saindhava. Lashuna, Saindhava is considered to be as it's a general prescription. So that's about one set of the diseases. The next area of cardiological conditions which we can see and we can manage is the coronary disorders. Coronary disorders doesn't mean heart attack or doesn't mean myocardial infarction. It's a evolving disease. If the blood supply to the heart muscle is reduced with hypoperfusion, initially it can be asymptomatic, later it can produce metabolic changes in the heart muscles which can result in a diastolic dysfunction, then the systolic dysfunction. Till these stages, the patient may not have ECG changes. There could be these stages are subtle, which may not be clinically observable. The ECG changes are seen after a significant reduction of the blood flow and the changes in the muscle tissue. So important is these early stages can be easily managed and can be preventable, and you can prevent the patients from going into the next stage. And many of the people who are otherwise considered to be normal, they might have gone through these stages at times and they might have got a spontaneous reversal. So it's exactly like the Sanjaya Prakopa Prasara, etc. Then the chest pain is seen when we identify this as the cardiac event, and then the myocardial necrosis would occur. Now, a patient with latent ischemia, where the ECG changes either are visible but the patient may not have any obvious clinical signs, there is a potential risk as such, and particularly we identify such patients who have a potential risk conditions in the resting ECG. That's normal, but when the patient does the exercise, after the exercise if you do the ECG, then there could be a moderate changes which can be reversed. So in these patients who have that early conditions, any of these, there could be that the patient may have a normal ECG in the resting condition. Only when you do the stress ECG, you may see that changes, and these otherwise the patient are asymptomatic, doesn't have the pain as such, and patient may not have a significant comorbidities. Other issues are not there. Now, when I suggest about all that treatment which I plan, it all depends upon the presence or absence of other comorbidities. In such conditions, my prescription would be, the one is the primary cause need to be evaluated, whether patients have to be evaluated very carefully for this cause as such, for the ischemic changes, and provided you do not find any such causes, my prescription would be, one best advice to the patients is regular pranayama. Regular pranayama can significantly produce a change in the outcome, and regular physical activity exercise also. And the usual my prescription would be Chandraprabha, Arjunarishta and Virechana in suitable patients as such, which can produce a significant outcome and prevent the progression of the coronary ischemia. So in the latent ischemic conditions, if you can identify such patients early with the stress ECG, and the patients otherwise do not have symptoms, there is no need to panic and they can be managed, provided we have ruled out all other primary causes as such. Now, the next is the patients who have the real pain in the chest as a symptom. Now, pain in the chest, again, need not be always a sign of cardiac ischemia, one of the clinically misleading clinical conditions. So, patients who present with the pain in the chest in general, which is considered to be in the left side of the heart, and you have that general criteria of the heart disease conditions, about 42% of the patients may have some gastroesophageal disorder like either GERD or esophageal disorders, peptic ulcers, etc. Only 31% of the patients who would have the real cardiac ischemic heart disease. The other causes, there could be many other causes which can present with the chest pain. So it's not that every patient presenting with the chest pain is a patient of cardiac pathology. The most important clinical signs which you have to be considered, which you have to be careful, would be if the patient presents the sweating, difficulty in breathing, and sense of compression, then really the pain in the chest, most possibly that patient may have ischemic pathology, and that needs to be considered, and that's considered to be one of the important criteria. Then of course the ECG is one of the other criteria. With the ECG also there is always a limitation, but the most important criteria is the ST changes, ST elevation in case of the ST changed myocardial infarction. But there is a group of non-ST elevation MI, without ST elevation also there could be MI, and those need to be considered with the care as such. To make out this, there is a general scoring system, and the scoring system would be based upon the multiple factors. Whether the patient has a previous history, suspicious history or moderately suspicious history, and significant ECG changes with the ST depression, age is a criteria, risk factors like other risk factors like smoking and so on. Most important, the reliable is the troponin factor, which decides about whether the patient has a cardiac pathology or not. And this is one of the general criteria followed to confirm whether the patient has a really cardiac event or it's some other condition as such. And this criteria is significantly reliable. Most important criteria would be the troponin level. Cardiac troponin level is very dependable to make the diagnosis of cardiac event, as well as this also helps in predicting the prognosis. The risk of mortality in acute coronary syndrome also is very much dependent upon the troponin level. So if the troponin level is at the range of 1 to 2, less than 2, this is definitely, yes, they are signs of myocardial ischemia, but I would consider this as comparatively low risk categories. If it is more than 2, it's always considered as a high risk category, and a patient with the high risk category, I would not treat that patient. I would always refer the patient to a facility where there is a ICU, because the next course is unpredictable. So from my Ayurvedic point of view, most of the times a patient with chest pain, they would always prefer to go to a contemporary medical center. They may not prefer to go for an Ayurvedic treatment. So scope of treating an acute myocardial pathology with our treatment is comparatively lesser, but still a few patients may be still preferring Ayurvedic treatment. In that condition, one of the important criteria is the risk prediction. If the risk is comparatively low, then definitely yes, we can treat them. If the risk is high, then definitely the patient has to be referred to the other hospital. Now, another category of the patients of coronary pathology, they might have gone to the other hospital, have then an angiogram, and angiogram shows a non-obstructive coronary arterial diseases. Now, this happens quite frequently in relatively younger patients, non-obstructive pathologies, where angiogram shows the blood circulation within normal limits, only the spasm, angiospasm is there. Such patients, they are the conditions where you may have the ST changes, and the coronary angiogram shows all the vessels somewhat intact, but the patient has some areas of ischemia, Such conditions, they can be treated safely, and my prescription would be the contemporary medicines like platelet aggregation inhibitors and the beta blockers or AC inhibitor antihypertensive drugs are necessarily prescribed, because there is always a risk asset. But with our medicines like Prabhakaravati and Arjunarista and diet and Virechana, they can be safely managed. But the most difficult issue in the clinical practice would be to decide about that, as we may not have the infrastructure to deal with, and patients of pain in the chest is always considered as an emergency. Opportunities to deal with such patients would be lesser. In my experience also, very few patients who are committed to Ayurvedic treatment, they may go to some other hospital, get the things confirmed, and then when they come over to us, we can manage, and such categories of patients are where we can produce some changes as such. But patients with obstructive coronary arterial disease, where there is a definite obstruction, in the acute stage, the next course is unpredictable. The problem would be, in an acute obstruction, in addition to the damage to the muscles, whether the patient will go into an acute complications like sudden death also, it depends upon whether the conducting system is involved or not. And nobody can accurately predict whether the conducting system is involved or not. And then there is a high risk. And if the patient's ECG shows very high changes, like and the changes are rapidly changing, the ECG changes are rapidly changing, like within a few minutes, the ST segment changes, pattern changes. Definitely, I would be referring the patient to ICU, coronary ICU, and I will not treat such patients as such. Now, once the patient has gone into a definite myocardial infarction, whether there is a scope, acute conditions of myocardial infarction, whether there is a scope for ayurvedic treatment or not, from that point of view, my perception is, depending upon the category of myocardial infarction, we categorize the myocardial infarction into mainly the 5+1, the injury. Now, that injury, myocardial injury, that sixth category is only from the cardiac surgery event where the patients are being operated upon for the cardiac surgeries, this occurs. Whereas the type 5 myocardial infarctions are within the scope of the general practice point of view. So, sixth category myocardial injury is a related to surgery, not an issue of concern from our point of view. Now, type 1 is the patients who have relative ischemia due to primary coronary event, such as a plaque or erosion, a part of obstruction conditions, and maybe some fissuring or erosions as such. Then patients of myocardial infarction type 2 are where the patient have a secondary ischemia, and in such these two conditions only there is some scope for medical management. Whereas the type 3, where there is a sudden unexpected cardiac death, or patients who have type 4, where there is infarction associated with the coronary intervention also, even after the coronary intervention, and patients who have myocardial infarctions with the cardiac surgery, history of cardiac surgery, generally I don't treat, and we don't get an opportunity to treat such patients too. So I don't have much clinical experience of dealing with these type 3, 4, 5 patients. Our clinical experience to a certain extent is limited to the type 1 and type 2 patients who have gone to some ICU and then come from the ICU and come for the treatment. So that in a coronary event we have a lesser scope for treatment as such. And in the type 1, type 2, again, if you have sufficient clinical information, then we can predict, and whether the patient can be treated or not is also depending upon the risk prediction. If the patient has already have that angiogram and that picture is known, then again we can see in the type 1, again you have that 4 categories, type A, B, C, D, and the patients who have a rupture or erosion of the thrombus, there you have a high risk of recurrence. And the patients who have a vasospasm, the outcome would be better. So then suppose, this is a real situation, and a patient goes to some ICU and has been treated there, and then he comes for Ayurvedic treatment. Whether I would prefer to treat that patient or not is based upon this information. Patients of type D, you can to a certain extent safely treat, and C also to a certain extent we can treat, but A and B, there is always a possibility of a sudden episode, another episode of the ischemia, and they are high risk categories, and generally I would like to avoid such patients. Type 2 infarctions, again, where the patient has a fixed obstructive pathology, there the treatment can be possible, or risk of the next course is not predicted. Whereas without a fixed obstructive coronary disease, then again there is always a risk of such second recurrence, or the recurrence of the second episode also can be predicted based upon the other criteria. In the type 1 myocardial infarction, if the patient has a relatively younger age, and male and younger age patients, and the patient has no history of smoking or so on, the risk prediction as such is not there, and the patients have more than 57% of the blood circulation intact, then the chance of if these type 1 patients who have a spasm, this clot which is eroded as the type 1 A and B, and the patients who have a high risk category like younger age patients and having the history of smoking and so on, then the blood flow is less than 57%, they have a high risk of developing another stroke within 30 days or another event in 30 days, and such patients generally I would like to avoid. and I would always keep such patients under the contemporary treatment. I would say, like, you wait for another few days and then come for ayurvedic treatment. Now the patients of the other category, where it's a fixed category, that's D or the spasm category, and as I told you earlier, if the patient is older and female patients and had a history of a cardiac event earlier, and the patient was being treated for the cardiac event earlier, there is a lesser chance of another episode within 30 days, and such patients can be to a certain extent safely treated. So selection of the patients in this condition requires a lot of homework, and then only we can select the patients accurately. That's from the selection of the patient. Now, approach to the treatment, I would be consider all these pain produced to the ischemic heart disease as Vataja Hridroga, as Vatena Shulita Tertan, Yudjate Sputivacha, Bidjati, Shushati, Stabdam, Shudam, Shuneta Dravaha, Akasmat Dinata, sudden development of the symptoms. These are the typical symptoms of the ischemic conditions. And the general prescription, again, as I said, the treatment in such patients are lesser, the experience of treating such patients are lesser, but when we treat, my prescription and my general approach would be in patients where we can treat type 1 and type 2 patients, its effective regulation of the hypertension is one of the important criteria. Whether the patient requires contemporary antihypertensive drugs or not is the other issue, but blood pressure has to be maintained steadily. Sudden reduction or sudden increase in the blood pressure is a highly risky issue. The use of platelet aggregation inhibitors like the salicylic acid and so on, they are essential and they cannot be prevented, so they have to be continued. Lifestyle modifications are the most important criteria. As far as the drug prescription is concerned, my usual prescription would be Prabhakaravati, Chandraprabha, Ardhanarishta, Punarnamandura, and exercises, graded exercise and yoga are the other important measures by which you can expect the patient to have some satisfactory recovery. Now, that's the issue. As far as the Prabhakaravati is concerned, Prabhakaravati is a Anubhuta Yoga used in Ayurvedic SDM hospital, and the contents are Swarnamakshika Vasma, Loha Vasma, Abraka Vasma, Vamsharochana, and Shuddha Shiladitu and Arjuna. These are the criteria by contents of the Prabhakaravati. Then, in all, whenever you deal with the cardiac issues, the practical use of cardiopulmonary resuscitation is essential. I will not go into that detail, but you should always be ready to deal with the resuscitation procedures in such patients because they are the life-saving measures. I will not go into that detail of how to do that. Then the question comes in coronary interventions, like whether the patient has to go for angiogram or so on. Many of the patients come for a second opinion, whether they have to go for angiogram, angioplasty and so on. To give you an advice is quite difficult, but as far as the real situation is concerned, the incidence of the coronary interventions are quite high now, and most of the coronary pathologies are now being considered as interventional areas. Even in the contemporary system, there is already a two school of thought, a non-interventional cardiologist and interventional cardiologist, and that dispute is there. I will not go into that part, but very sensitive issue when to give the patient's advice or not. So I will not go into much detail about how to give the advice, but that needs a lot of clinical experience and a lot of up-to-date information about the possibilities. Then comes the next category of cardiac diseases is the pump failure, where the heart is not able to pump properly, which we call as congestive cardiac failure conditions. That congestive cardiac failure conditions, I would be considered as the diseases really the hridrogas, where hridyabhihate kasa shwasa balakshaya kanta shosha kloma akarshan jihva nirgamam khataru shosha apasmar unmad pralapachitanashadesyu. That's the real hridya abhihata. Heart attack, according to Ayurveda, is a pump failure, or that's what we consider as heart attack now. Then in the kapavruta hridaya, kapaja hridaroga, shleshmana hridayam stabdam parikam sashmagam bhavata kasa agnisarda nishthi vanidra alasya ruki jwaraha. Or kapaja hridroga, again, it also presents with the cardiac myopathies or pump failure conditions, the same issue. Now, from the current category point of view, how to treat that, how to approach that patient is The NIHA classification would be patients of class 1 pump failure would be where the patient would have no symptoms, no limitation of ordinary physical activity, only shortness of breath on walking, climbing stairs, etc. They are class 1. Class 2 is mild symptoms like mild shortness of breath and slight limitation of during ordinary activity. Class 3 is marked limitation in activity due to symptoms and even during less than ordinary activity like walking, so on. Class 4 is severe limitations. Now, from our management point of view, I would always prefer to treat the patients of up to type 3 categories or class 3 categories. Class 4 categories, it may not be possible to manage with our treatment alone. We need to follow the contemporary line of treatment, and most of the times digoxin may be prescribed, either co-prescribed with our treatment or may be prescribed otherwise. Now, most of the times I would be preferring Ayurvedic drugs as co-prescriptions than really the main part of the treatment. If the patient is on digoxin or if the patient is on antihypertensive drugs, I would not try to change that. I would be prescribing our drugs like Chandraprabha, Punarna Prabhakaravati as the drugs, and that can give you a significant benefit as such. Then the other relatively less common conditions of cardiac origin which we treat would be carditis or pericarditis, which I consider as a pitta jahradroga. Incidents are lesser, and most of the times the patient would have some other disease like rheumatoid mechanism. CRP level is one of the important diagnostic entity, and in these conditions again, whether we can treat or not, it depends upon the patient's current status. Patients of carditis, pericarditis also can present with the acute emergencies, and most of the times the patient would be having treated elsewhere and then they come to us, and in such conditions usually Kaishara Mrityunjaya Amritarishta is prescribed as a co-prescription. Then another area is rheumatic disease, that's the Krimi-Jahradroga, where the clinical symptoms are exactly the same, and the incidence of rheumatic heart disease is significantly reduced now based upon the data. Earlier we had more of rheumatic heart disease conditions, now the incidence is getting reduced remarkably, and from Ayurvedic point of view, patient of rheumatism, we can definitely prevent the cardiac complications by treating with the Amavata Chikitsa like Gokshara Mrityunjaya Amritarishta. The prophylaxis with the penicillin is not absolutely necessary, we can prevent the complications. That's about the main course of Ayurvedic treatment as such. I think I have crossed the time limit, but anyway, a few of the other issues, offbeat issues. Every ECG change doesn't mean that the patient has a ischemic pathology. So if you have a patient with the ECG changes, you have to consider the other possibilities. ECG changes produced during vomiting can mimic that of ischemic heart disease. That again you have to be careful, don't be misled. Similarly, cholecystitis also can present with the ECG changes which may mimic cardiac events, and after few days of treatment that can reduce. So you need to be careful, you have to avoid that. Now another important area where we can produce a significant change is the complications produced with the statin prescriptions. Now these days the statin prescription is a very common thing. Every patient above 40 years having visited any modern doctor, now modern medicine doctor, would have a statin prescription as a common issue. And the statin prescription has resulted in significant incidence of the adverse effects, and the most common adverse effects are myopathies, the muscle aches and pains, which are the very common issues. And most of the patients who in the younger age who have statin prescription, they develop these symptoms, and one or other day they will definitely come to an Ayurvedic practitioner. And though as per the contemporary data, the issue is not highlighted, but practically we see such patients of cardiac, the statin-induced myopathy quite significantly, though there may not be any objective evidence of the myopathy, but symptoms of vague pain, which usually people say as a vata, they will come out there. And very interestingly, many of those patients, they are diagnosed as vitamin D this insufficiency. Now this has become a practice culture, like studying the vitamin D and then having that lesser vitamin D is a common prescription and common incident and common prescription of vitamin D. And very interestingly, that doesn't really resolve the issues. But patients of that category, they can be effectively managed. Whether you stop the statin or whether you do not stop the statin, can be effectively managed very well with Ayurvedic treatment. Kaishara Mrityunjaya and Amsarista, in my experience, is a sure shot remedy for this statin-induced pathology, which I consider as a amavata. And a huge number of patients, because the number of patients who are being treated with this statin and who have an unsatisfactory outcome with all the contemporary treatment, they come to Ayurvedic treatment, and where we can produce a huge change in the clinical outcome and gain the faith of the patient would be Kaishara Gugula Mrityunjaya Varista asset. That's one of the sure shot remedy assets. Now another issue of course importance is as I told in the beginning, target pressure issues, whether the blood pressure, which is the ideal blood pressure asset. There is a lot of issues. I think I am not going to that part. But one important fact which is known, the data is known, like if the diastolic pressure has been reduced to less than 60 or the systolic pressure is reduced to less than 130, the incidence of the coronary diseases, cardiovascular diseases, equally rises as it is going beyond the range of 140. These kinds of the data are now established, and the lot of these discussions are going on in the contemporary system about this issue. So one of the important issue is we need not follow rigidly what those benchmarks which are suggested by the associations are maintained. Lower BP may increase the risk of the cardiac events, which is well known. Now it's being proved as such. So that's the important issue. Like, of course, it's not my opinion. Now, one of the very popular notion is what makes an ordinary intervention cardiologist is extraordinary is he has an ability to create a dramatic complication and successfully tackling it too. Ultimately, the punchline is whether the heart is the seat of emotion or whether the heart is the seat of life, and so on. Now, what we now consider in general, the brain as an important area of regulating the emotions, but from Sushruta's point of view or Ayurvedic point of view, Hridayam Chetanasthanam Uttam Sushruta Tamo Vipite Tasmin Saritra Vishatrehinam. So whether you follow the heart or whether the brain, whenever you say your identity, you touch your heart or whether you touch your head, that depends upon that. But ideal is follow your heart, but take your brain with you. With this, now another is now it's now known that a recent study from cardiologists at the University of Maryland has shown that laughter has the most beneficial effect on the heart. And another important issue, these are all offbeat issues because I may not able to cover that. The World Heart Day is celebrated on 29th September every year, and the slogans of the heart, this Heart Day in the past 5 years are my heart, your heart, and so on, something like where there is a relationship with the social life. Now, instead of going to these variable slogans, I would say Nityam hitahara viharasevi samikshakari vishesha saktah data samaha satyapara kshamaman aptopusevi bhavatya roga. And this slogan can be a permanent slogan for the Heart Day. With this, let me conclude. Sorry for having overtaken the time limit. Then the carry home points are cardiovascular diseases, lifestyle diseases, and preventable principles of Swasthata are the beacon of hope for the future. Ayurvedic principles of management have a significant role to play in the management of hypertension and cardiac diseases, though the focus is on high tech. Now, the technique is important, and that technique, we cannot avoid that technology. Judicious combination of current knowledge with the ancient wisdom is the need of the. With this, let me conclude. Thank you. If there are any queries, I think I try to answer those queries. There are some questions, I think. Asymptomatic high blood pressure patient who have proteinuria, creatine levels slightly higher than, of course, proteinuria, creatine levels, if they have this, I would not consider them as asymptomatic. I would consider them as symptomatic, and then they are risk prone, and then we will have to change the category. They have to be categorized into higher categories. Definitely, yes, I will be treating with the Chandraprabha Punarna Mandura as usual and follow up, but follow-upping with that proteinuria issue is one of the issue. Of course, I have not dealt with the proteinuria in detail today because certain of the facts we can't manage with 1 hour's time, so that is one area. Then what's Patya in the case? Patya, of course, is any of Vidahi Ahara has to be avoided. Then atherosclerosis management in Ayurveda. Of course, it's a very detailed issue. We can prevent atherosclerosis. I don't say that I can treat a patient of atherosclerosis. Definitely, yes, prevention of atherosclerosis is possible, and that's what we have discussed. Like if you can prevent the hypertension, if you can treat the hypertension, atherosclerosis can be prevented. Then hypertensive changes observed in ECG, but no clinical signs and symptoms should be treated. Yes, if there are hypertensive changes in the ECG, definitely yes, I would consider that as a condition which needs to be treated. But as I told you, ECG changes are not always consistent, so you need to confirm like whether they are consistent or not. Then, sir, can we control the spikes in hypertension usually observed in people with anxiety? Yeah, of course, in the anxiety patients, Sarsuarista is a better option of the treatment. So, unstable hypertension, of course, that's one of the issue. Again, time if at all hypertension alone is a topic, we could have discussed that part. Like the labile hypertension conditions. Labile hypertension conditions can be effectively treated with the Sarasularista, Takradhara, also is another of the choice which I generally describe. Of course, that part I have not referred to in the present discussion. Then, right, that's about certain of the queries. With this, let me thank you and conclude. Okay.
Any delegates having any of the doubts? Any delegates? You can unmute yourself or you can post it in the chat box.
Right.
Sir, very high hypertension. Yeah, example around 180 by 100 mmHg. Can it be managed with Ayurveda?
No, I don't say that we can manage the patient only with Ayurvedic treatment, but co-prescription for Ayurvedic treatment can definitely produce a significant outcome. So, in such a high risk patient and very high patient, recurrent patients, I would always use our treatment as a co-prescription. That's what I have clarified. Hmm? Okay.
Any more doubts? Anyone would like to ask anything? You can unmute yourself.
A very good evening, sir.
Hmm. Yes,
Sir, uh, sir, what is the role of Arjuna? Is there any role of Arjuna, Arjuna Risht, Arjuna Churan, Arjuna Sheer Pak? In which stages we can give these three?
see, I have, in my observation, Arjuna is helpful in increasing the tone of the cardiac muscles. So, whenever there is a pump failure, Arjuna has a better role than the ischemic conditions. It's my opinion, what I have observed. And I generally prescribe Arjuna Vista in the patients who have a pump failure, the pumping abnormality, than really the patients who have ischemia. Ischemia conditions I would consider as the Rakta pathologies, varieties of the Raktavarana, whereas pump failure as the Kaphavrata. So Arjuna is better in that condition, Kaphavrata conditions, than really the Raktavrata conditions. That's how I assess it. Of course, I will not go into that objective issues of the researchers and that studies with the models, like that kind of issues is not that. It's about the practical observations, right?
Okay, sir. Sir, one more question we are having, sir. Sir, what is the role and mode of action of Urobasti on Hriday Rogas?
I don't know. I have never tried urobasti in any of the patients, so I don't have any experience of that.
Any kind of lepas, sir?
Huh?
Lep,
Lepas.
any kind? Yes, yes.
Lepa.
Lep.
No, I have not
Yes.
tried. I have not tried that, so I have no comments on that. So I'm
Okay.
just suggesting about what I have tried and my clinical experience. And as far as the textual descriptions, there are not much like urobasti. I don't see any textual description of urobasti, right?
Okay, sir. Okay, sir. Thank you very much, sir.
Thank you.
Thank you, sir.
Thank you.
So anyone have any doubts?
So, sir, today we think sir has explained in a very beautiful way all the things that nobody is having more doubts. One question is there, sir. Acute management of CAD in Ayurveda.
No, as I see, my experience is, I say, see, when we treat with the patients with diabetic treatment, our my priority is the patient should not lose the facilities of the contemporary system. The safety of the patient is an important criteria, and when we do not have a very definite means of assuring the safety, I try to depend up. I will not just take the risk in that condition. So that's what I have told you in patient, and that risk categorization, assessment of the risk. I have given my criteria as such. If the patient has a high risk as such, I would not treat that patient with the standalone Ayurvedic treatment. Then co-prescription of our drugs along with the contemporary system is another issue, which I have already explained. So I, instead of repeating the same, but safety criteria, risk assessment is one of the important issue when we deal with the cardiac patients. Not only cardiac, it's true for any other patient even. And I consider that as a very serious issue and very critical issue in dealing with the Ayurvedic treatment. I think I
Okay,
have.
sir.
Sir,
Yes, sir.
did you find some time with some drug interaction between both the systems?
No, I have never found that. With these prescriptions which I give, I have never come across any such complications.
Sir, one more thing we want to ask. Like nowadays, most of the patients are on allopathic drugs. They're already taking blood thinners or hypertension medicines, antihypertensive. So, if they want to approach us, so what should be our mode? How we should taper it slowly, or we should stop them? How to do these things, sir?
Yeah. That's again depending upon the clinical condition of the patient. See, I do agree. Lots of patients are given unnecessary medicines. So I generally say this modern contemporary system of medicine, the practitioners, it's not the defect of the system. So the practitioners, the number of prescriptions are very high, and in a large number of patients, reducing those drugs or avoiding those drugs itself can relieve the patient from many distress. So large number of patients come to us with adverse effects. Now whether those drugs can be stopped or reduced or so on, that depends upon a thorough clinical assessment. And I have given you some of the clues. Now when we have discussed, I have given you some of the clues like where we can reduce. But it's quite important that you should know the pharmacology of the contemporary drugs, and should know all the risks of withdrawal, and then only considering all that risks and the advantage, then only that has to be reduced. So that's a very elaborate case specific issue. In general, I would say like you need to consider the safety of the patient. With a very specific case description, I can say like which of the drugs can be reduced, which of the drugs cannot be reduced, and those issues have to be based upon your thorough knowledge. Or rather, I would always say like if you have to be a successful Ayurvedic practitioner, you should be more modern than a modern doctor. So that contemporary systems, we should be very updated. Then only we can have a successful Ayurvedic practice. I think.
Okay. Okay, sir. Sir, one more question. Sir, in post-corona time, mostly people are suffering from dyspnea and palpitations nowadays without having any major heart problem, but they doubt that they are having some of the cardiac illness.
Yes.
So, how should we look into this?
Yeah, that's another very significant, interesting issue. And of course, coronary events also have increased after the COVID pathology. And those patients who do not have an objective evidence, I would always consider this as a Jvarottara Daurbalya with the Ama or Agnimandya. And I have treated a large number of patients with the Arogyavardhini and Ashwagandha Vista with significant clinical satisfaction. So we do not have an objective criteria to say whether the patient has recovered or not. It all depends upon what the patients feel and how the patients will behave. And with that, I think I may be in a position to say as a general prescription for the Coronottara Daurbalya, the after the complications of the corona, as Arogyavardhini and Ashwagandha Vista in general. Very simplified answer or very brief answer. I think.
Okay, sir. And sir, one more thing, sir. During pregnancy, most of the females suffer from hypertension, or they are in risk of preeclampsia, like
Right.
this situation. So, how
Right.
to deal with our drugs, sir, in those
So
conditions if they are on?
I
Yeah.
keep that. See, pregnancy and hypertension is an issue which I don't handle at all. If the patient has a pregnancy, now there are two lives and the safety of both the lives are important. And I don't deal with our drugs at all. It's totally left to the contemporary system, because the eclampsia and the risk to the fetus, these are all the conditions which we cannot easily manage, and we do not have a standardized methodology for that. So in practice, I just avoid them. I advise the patients to go to the contemporary system alone. I don't treat with Ayurvedic treatment in such conditions.
Okay, sir. Sir, do you? We would love to hear you from your experiences on any wish dravya treating heart disorders which you
Any?
are using frequently. Any wish dravya.
Vishadravya. I have
Yeah.
not tried that. Vishadravya, I have not tried that. I have not tried that in any of the heart diseases. I don't have any
Oh,
experience.
okay, sir. Sir, a sincere thanks to you for taking our class on this topic. Sir, it's great to have you with us. And we thank you again from Indian Institute of Ayurveda and Rasashastra.
Okay.
And
Thank you.
yes, yes, sir. Over to you, Dr. Gopi Krishna, sir.
Yeah. Thank you, ma'am. So thank you, sir. Thank you very much. It was a wonderful session. And one last question from my side, sir, because many times I find people asking this chronicity of the drug which we give, especially like hypertensions and all, where we plan to give Chandraprabha, Punarnava and all, might be we have to give for a very long time. Did you find in your experience like it has become a Dhatu Samhita and it is almost neutral in its clinical efficacy, or we can give it for a long time with good therapeutic benefits?
See, I have seen this in large number of patients. I am practicing since 40 years, and I have patients who are taking Ayurvedic drugs for more than 40 years continuously without any interruption, and virtually there are no complications. So it's not that we prescribe the drug randomly with the specific indications. Definitely, you need not worry about the drugs being prescribed for a long time. Then the other question is like sensitivity to Ayurvedic drugs, like whether the patient becomes resistant to the Ayurvedic drugs or adapts to the Ayurvedic drug or not. In my experience, it is totally the other way. As far as the contemporary drugs, modern drugs are concerned, when the patient is given that drug for a long time, the patient gets adapted to the drug. But when we give Ayurvedic medicines, patients become more sensitive to. See, I have a large number of patients who are on Ayurvedic treatment alone, my committed patients, who do not take any other medicines. And may not be in the conditions like hypertension and so on. It's in the certain short duration disorders like common cold, fever, etc. Patients who come for Ayurvedic treatment with common cold and fever, who were taking earlier the other modern medicine, my prescriptions may have to be given for 1 week or 2 weeks or so on. But if the patients are on Ayurvedic treatment for a long time, never taken any modern medicine, simple 1 day's treatment, 1 dose of the drug would be enough to produce the same relief. So this is, I will say, Ayurvedic conditioning. And as far as myself is concerned, I don't take the medicines even. The handling of the tablets during the clinical practice itself would be enough to treat my conditions. So when I develop any cold or fever, I don't take Mrityunjaya Rasa. But because I handle that Mrityunjaya Rasa, and that's what I feel that it's not exaggeration. It looks like exaggeration, but it's not real exaggeration. But that's the real issue. So if you are not taking the other contemporary the specified molecules, targeted molecules, and you are taking Ayurvedic drugs regularly, you become more sensitive to Ayurvedic drugs, and these Ayurvedic drugs would produce a better relief. So in the long run, Ayurvedic drugs, the requirement of the Ayurvedic drugs gets reduced, and there is absolutely no safety issues and giving for a longer duration if there is a specific indication. So without indications, giving the drugs is not justified. But if there is an indication, it has to be given for a long time. I think I have answered that satisfactorily.
Yeah, very much, sir. It was a golden word for us because many have this query like, can Ayurveda medicines given for a long time? Will they have any resistance and all? It was very clear, and your experience is a very much evidence and proof for us for this. So, anyway, sir, thank you very much for giving your precious time for us and explaining us the whole concept in a nutshell. Very beautiful explanation to the level how it has to be understood for a common practitioner.
Okay,
So we from Vedant Rashashastra, thank you very much for being with us and gracing this occasion. Thank you, sir.
Thank you, sir. Thank you, sir. Thank you.
Thank you.